we will discuss troubleshooting. First, peak pressures. One of the most common things a physician will be called to evaluate on a mechanically ventilated patient is the development of constant beeping on the part of the machine, which is most typically the result of excessive peak pressure development. It is important to first and foremost look at the patient and see if the patient is distressed or are they obviously biting the endotracheal tube, and what they need is sedation as well as an assessment of what is the cause of the patient's distress. One would next pass a suction catheter through the endotracheal tube to see if by chance the ET tube has been crusted with secretions, or to find further evidence that the patient might be biting the endotracheal tube. One would then check the peak and plateau pressures. If the pattern is consistent with primarily an increased airways resistance, one would recommend the delivery of bronchodilators. If, on the other hand, the pattern was most consistent with decreased respiratory system compliance, one would check a chest X-ray, primarily to look for a misplaced endotracheal tube, perhaps down the right main stem, to look for evidence of a pneumothorax, to look for massive effusions, ascites, or other causes of poor respiratory system compliance. In terms of reducing the peak pressures, one could consider a lower tidal volume, a lower flow rate, and or sedation, depending upon the cause. In terms of assessing endotracheal tube position, what is considered appropriate positioning? Well, first and foremost, it needs to be in the trachea, below the larynx, and you would like it to be above the carina by at least 2 centimeters so that it would minimize the risk of it being advanced inappropriately down the right main stem. Assessing position of the endotracheal tube can be challenging. At the time of intubation, it should be noted how far advanced the endotracheal tube is as measured by the corner of the mouth. On average, in men, that will be 23 centimeters, and in women, 22 centimeters. Once the chest X-ray has been assessed, one could confirm that these measurements are appropriate for that patient, and at a future time, if it seems that the ET tube has migrated and as measured at the mouth these numbers are different, one would be concerned that the ET tube has been mispositioned. As demonstrated in this chest X-ray, one would identify the tip of the endotracheal tube by seeing the opaque line on the endotracheal tube ending at its tip, and one would identify the carina and would like this distance to be at least 2 centimeters. It should be noted that if one can identify the patient's chin, as the patient's chin moves downward on the X-ray, so will the endotracheal tube position, and as the chin moves upward, so will the tip of the endotracheal tube be pulled higher within the trachea. Further issues in troubleshooting. Frequently, you will be called to see a patient who is experiencing desaturation. When that happens, one should place the mechanical ventilator FiO2 to 100%, and if that does not immediately improve the situation, the patient should be disconnected from the ventilator and manually suctioned and bagged. If a patient has an inappropriate cuff leak, meaning that with the cuff fully inflated, air is delivered by the machine, but a smaller tidal volume is returned to the machine, it implies that the cuff is leaking and the balloon should be inflated, and if that does not rectify the situation, the endotracheal tube will need to be replaced. Patients will occasionally self-extubate. When this happens, the patient should be urgently assessed, and in general will require reintubation by activating a doctor respiratory. However, if possible, one would like to assess the patient to see if by chance the patient is actually capable of sustaining ventilation on their own. However, this assessment should not delay reintubation under most circumstances. Patients on a ventilator who develop shock should be evaluated for the possible development of a pneumothorax and or excessive autopeep. And if you're managing a patient with a tracheostomy and the tracheostomy is new, having been placed within the last 4 days, and it becomes dislodged, one should not try to replace the tracheostomy tube through the tracheostomy hole on your own. Rather, you should maintain control of the airway through bag ventilation and or orally intubating the patient while consulting ENT to correct the situation.